Let me now please introduce you to Charles Goddard from The Economist.
Thank you, Tanya. I won't shake your hand because I know you have a cold. you wouldn't know, but Tanya got off a plane at 4 o'clock this morning. Robert, thank you too for calling out The Economist. I myself was surprised at how much we advocated for universal healthcare, and I think enormously good that we did. Not that it necessarily makes a huge difference that The Economist does that, but nevertheless, I was surprised and encouraged. Let me invite up to the stage for this session on providing sustainable coverage of cancer services. Francesca Colombo, please. Francesca is the head of the health division at the Organization for Economic Cooperation and Development. Welcome, Francesca. Hi. I will shake your hand. Shall we? We're going to be a long way apart, but let's
where do you want me to
sit on opposite sides
here?
so the
All
camera
right.
can catch
Okay.
us both. I just wanted to, almost to pick up on Robert's point, first of all, but let me just start by just focusing on this question of public financing and the sense that public financing of health services is really considered to be, I think, the main driver for countries to make sustainable sort of progress towards UHC. And then picking up on Robert's point, the sense that there's been years of debate around this, and public financing, I think, the sense that there is a role for the private sector and private financing, and how that plays into it as well. A very economist question, but let's take the first one first. What about public financing and the role of it?
Yes, and I represent the OECD countries, which is really the high-income countries. So I think there are both positive and perhaps negative lessons around universal health coverage and financing that it's useful to hear. And I divide up into two main issues. One, it's about achieving universal health coverage, and the other one is about sustaining universal health coverage. Now, in achieving universal health coverage, and we have heard it quite loud and clear, the important role of public financing. If we look at what happens at OECD countries, and most of them, with some exception, most of them do have universal health coverage right now. And they've achieved it through dedicating and really allocated resources out of their budgets, the government budgets, into health. So a clear allocation and prioritizations of spending going to health, and that's public spending. And this has been really a driver of achieving universal health coverage. And so if we look at countries right now which are, if you want, some middle income and some of the low income countries, actually they have level of income per capita which are comparable to the level of income per capita that OECD countries had when they achieved universal health coverage. If you look at Japan, you look at Germany, you look at France, when they achieved universal health coverage, they were, in a way, middle-income countries. They were not high income. They had a level of income per capita that made it possible and affordable to achieve universal health coverage. So there is a very, very first important lessons in achieving universal health coverage that, yes, it is a political process about prioritization of public financing, but it's something which is possible for a very, very large number of countries across the world. It's not something that only the rich countries can afford and should afford. So that's the first thing. The second issues which become more tricky is, well, once you have achieved universal health coverage, well, you need to sustain that. And it does not come in an automatic and easy way. And so the experience that we have seen in OECD countries is that cost goes up inevitably. And it's, the spending on health, particularly as income of individuals goes up, it's obviously what people want. We've done also a survey that looks at risk that matters to people, and health came as the very, very first risk across, again, OECD countries that they think that the people want to make sure that it's covered and insured. So health, very, very much of a priority for individuals, but inevitably the costs go up, and that creates an issues for governments. How do we sustain the financing and the coverage once you have already achieved universal health coverage. And that's where the public-private issues become more of the...
So have we seen a substantial increase in healthcare spending in OECD countries? And what are some of the patterns that you're now seeing?
Yeah, so I mean, in high-income countries, OECD countries, now about 9% of GDP is devoted to health spending. And 3/4 of that is public financing, so it's very, very important to say. But I think what is often not talked about is the fact that if we look at the government spending, about 15% of government spending is devoted to health. And as cost goes up, there is a limit to how much health can crowd out other parts of the economies. And this is one of the main challenges is then sustaining universal health coverage once you have it. That if you already have a significant part of government spending, and of course you need to get there, you need to have that prioritizations and political prioritization to get there, but you then need to sustain it. You need to make sure that what you spend, the extra dollar, the extra euros that you spend is delivering good money and good results. And I think there is again a lessons to learn, and perhaps it's a negative lessons, if I may, from advanced economies, which is really about what we say actually and the importance for low middle income countries to skip generations of reforms. Yeah. I mean, what high income countries did is that they built up systems which are around episodic care, which are about hospital systems, which are about acute care. But talking about cancer, talking about non-communicable diseases and chronic conditions, we need a completely different health system, a health system that prioritizes primary health care, preventions, and so forth. And so what we really ask and encourage countries to do is to skip that generations of reforms, like move beyond what high-income countries have done and build a health system which is more suitable for the needs of people.
So what are some of the, what you're saying is that health system reforms and health system transformations, particularly in countries where they're deeply incumbent. So a lot of the high-income OECD countries have had health systems that have been sitting there for a long time and are quite incumbent. To what extent are those reforms fundamental in addressing the long-term sustainability, and what kind of reforms are we really seeing? We're seeing aging, we're seeing chronic diseases rising, we're seeing more expensive treatments and more expensive drugs and so on and so forth. What are the kind of reforms that need to take place in countries to meet that sustainability issue?
Yeah, it's really rethinking about health systems to be about the primary health care and the prevention. Preventions in OECD countries accounts for about 3% of total health spending. It's very, 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 very tiny. And we know that we are talking about chronic conditions. The preventions and lifestyle choices as a particularly important matter in changing outcomes. Now, when there was a financial crisis a few years ago in 2008, the first thing that was cut in many countries was actually prevention, because it's easier in a way to cut those costs as opposed to spending, say, on hospitals where you have budget systems which are incredibly rigid. And so, the very first thing is obviously trying to reorient spending much more in prevention, which is, and there is ample evidence now, it's cost effective and it has knock-on effects also on the economy. Let me just make an example. We released just about a week ago a report on obesity and the heavy burden of obesity. And we know that obesity is a risk factors to many chronic conditions, including cancer. And what we're seeing in that is that the economic cost of obesity for the economy, it's including not just the health spending cost, which is about 8% of total health expenditure, but also the cost in terms of lost productivity, in terms of educational outcomes as well of individuals and so forth. All of that added up together, it comes out to 3.3% of GDP. And this is not just back of the envelope calculations, they're done by linking the OECD chronic disease model, which is a very sophisticated model on cost effectiveness of chronic diseases, with the OECD macroeconomic models of the growth of the economy. So 3% of GDP goes down to obesity. So it's quite clear that if we can do something to address those risk factors which are behind many chronic conditions such as cancer, we will have knock-on effects onto the economy. And that's, you know, the selling, if you want, argument for prime ministers and leaders. It's not just about the health burden that poor health, has, but it's really about the economic opportunities of having people who are in good health and can participate into the labor market.
So what you're saying actually is that there's a growing recognition, the evidence is telling us that prevention, even in advanced health systems, was underfunded and effectively not as I suppose attractive to policymakers. What is it that we need to do? If you look at, say, recommendations from CanCon and a range of other organizations around what needs to happen in cancer control, a lot of it now has to do with prevention and early intervention. What is it that policymakers need to understand now about how that is important? Is it the economics? Is that going to persuade them? Is it going to be...
Well, the economics is certainly quite important. That's why, at least in OECD, we spend a lot of time in trying to look at what the economic arguments we are beyond investing in prevention, for example. So looking at not just the economic consequences of risk factors, but also at the cost effectiveness of different interventions. And, it's quite clear the interventions to tackle risk factors which are behind cancer and other chronic diseases are, in many cases, cost effective. They are worth the investment. The return on investments, for example, of different interventions to tackle obesity are in the order of $1 invested, you have about $6 to $8 return. So the returns are really quite high. I think when talking about cancer, and it's definitely, again, this orientation on prevention, but also thinking about the overarching governance of cancer care. I mean, we've done some work, some analysis a few years back that showed that countries that had very good results in terms of cancer outcomes had a few features. The first one is that they invested sufficient resources. I mean, of course, that's, a starting point. So you need to have a minimum level of investment that you have. But the second one was that they had a particular good combinations of policies and of governance that really did make the trick. And they started obviously with prevention, but also with universal screening procedures, with having data systems that were enough to really monitor what is happening in terms of survival, in terms of screening, and so forth. So that you had state-of-the-art implementations of evidence-based guidelines and practices and so forth. And it's, in a way, it's the combination of all these factors that made the trick. And we did this analysis through typical OECD work, looking at econometric analysis and what are the determinants of good outcomes. So in a way, while spending, it's the very initial starting point, hence the importance of public spending and prioritizing public spending. It's that overarching governance, putting all the different elements together, that really does the trick.
I think you raise a really interesting point there, that picking a country like the country I'm from, the United Kingdom, where it's now, recent studies have shown that healthcare, particularly cancer outcomes, have not been comparable with peer countries like Australia or Norway. And that part of the problem is not just related to the cancer care itself, but actually to the system and to the health system. Yeah. What is it, do you think, that countries like UK, which are probably falling behind, I'm going to ask you, of course, somebody from the OECD is not going to want to mention, criticize that, but what is it that countries like the UK could be doing around health system strengthening that would help the cancer outcomes?
Yeah, well, first of all, let me say a few things, good things about the UK. Yes, it was lagging behind a lot on cancer outcomes, but it has catch up. So it's, I think that's a good sign that they're going in the right direction. So I think there is an important issue when we talk about universal health coverage. There is lots of attention which goes into the financing and the coverage of services fundamental, but perhaps not enough attention to the quality of healthcare services. And one of the things that we have been saying quite loud and clear is that universal health coverage without quality is an empty promise. With its tripartite reports, the OECD, together with the World Bank and the WHO a few years ago, that really demonstrated the importance of putting quality health services, so effective care, safety of care, and also people-centeredness and responsiveness of care, very much higher on the agenda. And if you don't have that, it's very difficult to attain, really, to make a difference in terms of economic outcomes. Now, very often when I also go around, I hear this like, well, quality is something only that the rich countries, again, can afford. And I would argue that's not the case. It's actually poor quality, which is what creates most of the cost and the unaffordability to countries. So in a way, there are a number of interventions to ensure quality of care, which are very, very easy in a way and cheap to do. I mean, it's think in infections control, things about the issues of washing hands, things about the issues of trying to implement more electronic medical records and using digital tools as a way also to reduce medical errors and so forth. I mean, there are a lot of things that are not necessarily costly or that require huge investment. So I would say that quality, prioritizing quality, it's a particularly important aspect when, besides obviously the financing and the other issues I mentioned.
So there are many things we haven't been able to talk about, and Francesca, I'm sorry, equity being one of them. Among the others, I think, is this sense of the private provision of public health care and the extent to which that contributes, supplements, or undermines public health systems. In fact, I mean, I do want to end on that note, because that is a serious challenge within some OECD countries about the public perception of universal health care and its coverage, and the sense that there is a growing role for the private sector and private funding around universal health care that some believe is a disadvantage to those systems, not of benefit to the systems, and others believe is a benefit. How do you work that through?
Yes, there is a fundamental difference between talking about financing and talking about provision.
Yeah.
I mean, if you talk about financing, as I said, like 3/4 of health spending in OECD countries comes from public service, collective service funding, and there is a reason for that. It's more equitable, and that's what we heard from Bob just before. Now, when we talk about provisions, it's a very different story, and in OECD countries, you do see that in many cases, the provision is either a mix of public and private, or in some cases, is really private providers, self-employed professionals, which are in the private sector. So what is more clear that is important here is really more how you regulate, and do you have standards for quality which apply to all providers regardless of whether they're public or private? Do you have a fee and payment systems which is the same regardless of whether the provision is public or private, and so forth? And that's where you make a difference. And when you talk about low middle income countries in which perhaps supply might be scarcer or not as widespread as in on the high income countries, you need obviously to bring in the private sector. That's an important source of delivery of services, but it needs to come with certain standards in terms of prices and in terms of quality. There is one thing which I didn't mention today, so when we finish, which I think is quite important, particularly in cancer and more general in chronic conditions, is that how do we measure the results of what we do? So there is obviously a lot which is important, and lots of data that we are collecting on volumes of healthcare, on utilizations, on spending, but we know tremendously little about really the outcomes beyond mortality and beyond survival. And I think it's quite important, and that's the next way, generations of statistics, to really focus about patients-reported outcomes and the perspective from the individuals themselves, and whether really the treatment that they have make a difference to their lives and ability to live a normal life.
Well, Francesca, as you said, there's so much we haven't been able to address, so, but do please join me. I've gone over time, I know I have, but do please join me in thanking Francesca. Thank you.